You're listening to Aging Uncensored.
All right. Hey, welcome back to Aging Uncensored. We are so lucky to have a very special guest today, Dr. Andrea Boohaker. I know Andrea from my time at UAB and when she was the lead in the ortho clinic, and the many times I've called her and said, OMG, please help me. Hey, Andrea, I have a patient. They need to be seen now.
Don't we all do that?
Unfortunately, tomorrow won't work. It needs to be now. And she's like, just send them, Chaeli. Just send them over. It's okay. So, really a pleasure to have her. Andrea's been a nurse practitioner for 17 years and has an extensive background in orthopedics, trauma, and now is in a leadership role. Is that right? Tell me what your title is at UAB now.
So Associate Vice President of Ambulatory Services and Advanced Practice Providers.
Love it.
Yeah.
Awesome. Well deserved.
No, I think you're sweet. Very
Well
humble, very blessed.
So I wanted to bring you on today to talk about, like, obviously orthopedic issues are something that affect everybody. Like, if you live long enough, like, you know, to age 5, you'll probably have one.
Right, every parent knows that a visit to the ER is in their future at some point. Exactly.
So, you know, when I was in the clinic, I dealt so much with orthopedic things, like acute things, chronic things. Even when I did home-based primary care and did hospice care, and I mean, there hasn't been a group it hasn't affected. And I think that there's a lot of challenges around that, especially with aging adults. Like, how do we make the right decisions? How do we know, like, is physical therapy still helpful? How do we know if we need to replace that knee?
Mm-hmm.
What if they break their hip? What do we do? You know, all of these things that come together.
Sure, makes sense.
So I want to talk a little bit today just about, like, in this conversation, kind of helping guide a caregiver or helping guide a loved one, or even an aging adult into kind of this, like, medical decision making around orthopedic care.
Yeah. So Chaeli knows me well. Orthopedics is kind of, you know, my love. It can be very daunting as any provider, like a nurse practitioner or a physician's assistant, because there's not a ton of that's really given, you know, in our training.
Yeah.
And so it can be a little bit intimidating, I guess.
Oh yeah, 100%. I can vouch for that.
But I'll kind of start with just quickly my journey and then get into what I have learned and what has helped kind of patients and families, because that helps us as providers, especially as we mature into our careers. I was very, very lucky to be in a position or in a environment where teaching was the number one priority. And I essentially embedded myself with the residency program that I was involved with at the time. And the physicians were treating me essentially just like a resident and giving me all the information that they were getting.
Beautiful spot to be in.
100%.
And absolutely should be that way for advanced practice providers. Creates better providers. Everybody wins.
Agreed. And really starting to understand, okay, how do I read an x-ray in a non-biased way so that I can create or at least formulate a treatment plan that's beneficial for the patient? Mm-hmm. And so that's really where it started, was understanding reading radiographs in a methodical, non-biased way.
I love that non-biased.
Yes.
Because I don't know that that's something I've thought about when I'm looking at it myself.
So there was a mentor of mine and I've used this in almost every lecture that I've given, he has a motto of seek disease, do not hope for wellness. So sometimes when you're looking at an x-ray, you're hoping that it's fine. And sometimes when you have that bias in your brain, you can miss something, right?
Oh, wow.
So if you go at it in a methodical way and understanding, okay, I know the mechanism of injury that this patient is presenting with today. what should I be looking for, and doing it in a, again, non-biased approach so that you don't miss a fracture and you don't miss something else. And then with that, also understanding you're not just looking at the bone, you're looking at the soft tissues, you're looking at density changes, you're looking at the quality of their bone, right? Not just for the fracture, but are they osteoporotic? Is there something unusual there where they had a fracture years ago, but maybe they didn't even know it, type of thing.
Yeah.
So it kind of started there, and that gave me the confidence to be able to empower my patients and their families, right? And so with that confidence came the ability to educate them in a way where they felt like they knew what they were doing. And that also gave them the confidence to ask questions. Just because I said something doesn't mean you should question what I say, right? If there's something you don't understand, or if I didn't present it in a way that you felt like you understood everything from start to finish, then you should feel empowered to ask me, what does that mean? So I love to pull up the x-rays together in the room with the family and the patient. And we walk through it and be like, look, this is what I'm seeing. Where are you hurting? And then really making sure that what they're telling me is matching up with what the x-ray is showing.
Yeah.
And then even beyond that, CT scans and MRIs or whatnot.
Yeah.
And really including you, the family, and the patient in that decision tree or that decision process.
Right.
Is me ordering an MRI going to change our treatment plan? Because if you don't want to do anything surgically, and there's no harm in continuing with conservative management, there's really no need to order an MRI, right? But making sure they understand what we're looking at on an x-ray and talking them through the thought process. Okay, this is what I'm seeing. Let's say, for example, in a wrist, right? You came in and you fell and you hurt your wrist. And I'm worried about a wrist fracture. Okay, well, I don't see anything on first glance. Let's go back to your wrist, point exactly to where it's hurting. And then we go immediately back to the x-ray and we look and see, okay, this is exactly where you're hurting on your wrist. Let's look at the x-ray and make sure we didn't miss anything. And they feel a better comprehensive, understanding of what we're dealing with.
Yeah.
Right?
Yeah.
And I think that that's important because it's not just a one-man show. It shouldn't be, at least, or at least, the way that I'm trying to teach APPs behind me, or NPs and PAs behind me, is that's really how it should be. It should be an inclusive approach. And then making sure that they feel heard, even though the visit is done. Okay, what questions do you have? What didn't we cover? Yeah. Let's talk about maybe what's going to happen after this. When you get home, if you forget something, these are the things that you should probably look for, and then reach back out if there's any further questions.
Yeah.
So I think the bottom line is, as a provider in the orthopedic specialty, making sure that the patient and the family feel heard and that they feel empowered to ask the questions that they want to ask.
Yeah.
Because what's important to the patient in room 1 may not be what's important to the patient in room 2.
That's exactly right.
And if we don't ask or allow the ability to allow those patients and families to ask those questions, we'll never know as a provider.
Oh my gosh, that's so right. And we talk on this podcast a lot, talking about what matters most and focusing on that, making that your Northern Star for decision making.
Yep.
And that's what I encourage and talk to families about all the time. And I actually went to an appointment with my father-in-law months ago. He went to see an orthopedic surgeon, spine surgeon. He has really severe cervical stenosis and some myelopathy associated with that. So muscle weakness and limited range of motion. It affects his quality of life in a big way. He has a lot of pain. It affects a lot of things for him.
Yeah.
We go, and he had previously seen a provider who was like, you need surgery. We need to operate. It's going to be a big surgery. There's no other way around it. And if you don't do it, then you're never going to be okay. Well, but there was a lot more to that conversation, so we go see another provider who's like, there's no way I would ever do that to you or not improve your quality of life.
Right.
What matters most to you, and this is just the reality of it, is that you can sit at your house and get a cigarette to your mouth. That's just what's important. No, it wouldn't have made, what was important to him, which is to not be operated on and to not have big interventions like that, be in a hospital and all of that, like, you have to think about that.
That's right.
You know?
You brought up a good point, and we always encourage second, third opinions. I'm not going to pretend like we don't know everything. We just don't.
Yeah.
And I always encourage, like, if I get a vibe that, maybe they're just not comfortable with the indication or with the treatment plan, I'm like, you know what? I encourage you to seek out another opinion. It doesn't hurt my feelings at all. And I think that that's something that families may feel hesitant because they don't want to maybe hurt someone's feelings or make it appear like it may come off as disrespectful, but truthfully, it's not.
It's not.
It's really not. And I think it's prudent, especially as caregivers, to seek that out for your family members, especially if they can't speak for themselves, right? You always want to have more information than less because you can make a better decision that way.
Yep.
And sometimes, not everybody jives with me. I mean, and that's okay.
Yeah.
There just may be a little bit of a better approach elsewhere, and that's completely fine. What matters is the patient and the family are happy with the treatment they're being given, and it doesn't matter who it's being given by.
Yeah.
And I feel like that can sometimes be lost in the mix, especially in this very volume-driven society and volume-driven healthcare like just platform that we're on. Volume is important, but the patient is what matters. And
That's right.
As long as the patient remains in the center, those decisions will always be made correctly.
Yep. I totally agree.
Yeah.
That's exactly right.
Yeah.
Let's talk about, so there's a myth I'd like to debunk
Okay,
here.
let's do it.
Okay. A fracture
Yep.
and a broken bone
Yep.
are the same thing, right?
True. 100% true.
Sometimes people think that it's just fractured, it's not broken.
That's right.
Okay.
We're changing lives today, Chaeli. So a fracture and broken bone mean the same thing. I'll be honest, I'm not quite sure kind of where it got crisscrossed or how there was a different definition. It's very common though.
It's so common.
Yes,
so if you
very
have felt
common.
that way, if you've thought that, it's fine.
That's right.
Totally fine.
That's right.
When you know better, you do better, as I like to say.
That's
so
right.
now we just all know better.
That's right. And no one will ever think less if you come in and say, oh, I thought I had a broken bone, but it's a fracture. Trust me, we get it all the time. We're happy to kind of help, point you more in the right direction, but fracture and broken bone mean the same.
Perfect. Good. Let's talk about, some of the most common things I deal with patients, older adults. So osteoarthritis.
Yep.
Huge.
Yes.
I mean, everybody's got it. I have some myself.
Yeah. It is one of the most common diagnoses we treat, 100%.
And so osteoarthritis is just mostly normal wear and tear.
That's correct. Exactly. So in joints, let's take the knee, for example, because that's a very common joint that gets osteoarthritis. Essentially, the definition of osteoarthritis means joint space narrowing, meaning that as we use our joints and use our body, things wear out, much like a car. The longer you drive it, the longer the parts are going to wear out. They need to be replaced or repaired or fixed or whatnot. And it's very similar when it comes to joints. So number one is joint space narrowing. And at the end of each bone that makes up a joint is something called an articular cartilage, which is a kind of a soft, shiny covering or coating to the end of the bone that allows us to move without pain. Well, naturally, as that joint space begins to narrow, those soft, shiny edges or coverings begin to wear down. And that's where the pain starts to kind of show up. And then as osteoarthritis begins to progress, you can start to develop some bone spurs, and then you start to get almost changing of the shape of the bone at the end, right? Because now that coating is no longer there to protect the bone on the inside. And that's where a lot of people begin to use maybe braces or canes or anything.
That's when things really start to feel unstable.
Exactly
Is that
right.
right?
That's exactly right.
Yeah.
But if you're dealing with osteoarthritis, fear not, it's coming for all of us. I joke that, as we kind of approach that 5th decade of life, that's really where you start to feel it in some of the joints. The most common areas we see it in are kind of the base of the thumb, where we used to kind of pinch and grip. We see it most commonly in the knees, and then people will start to feel it in their backs as well, especially if you have jobs that require a lot of lifting. But osteoarthritis is extremely, extremely common. It is very treatable. We start very, very simple bracing, therapy, maybe some over-the-counter medications, and then you can progress to more invasive treatments like injections, and then ultimately, if nothing's working or if you get to a point where you just can't take it anymore, then there are surgical options available.
So let's talk about injections a little bit.
Yeah.
So I know when I was in clinic, people would say they got chicken fat injected.
Rooster honeycomb.
Rooster honey. What is that? Rooster comb.
So there are different types of injections that you can get, and they're indicated for certain joints. So we can stick with the knee since that's the example we used to begin with. First line of injections that we typically recommend are steroid injections or a corticosteroid injection that's mixed with a lidocaine or some type of pain reliever. And that's what we usually recommend right off the bat. There are can be some contraindications to that, especially if you have your diabetic patients, if their blood sugars are uncontrolled. We tend to be a little weary of that. Then you can move to your what we call viscosupplementation, which is the rooster comb. There are different products out there, but essentially, that's right. It's essentially what it is. Essentially, what we're trying to do is mimic what the joint fluid is in the body, and so inserting or injecting this gel-like fluid to almost buy you some time or extend the life of the joint as long as we can. There are, again, indications for that as well. Some people may not be the right candidate for those types of injections. So there are things that your provider will talk you through to ensure that you are the right candidate. And then there are also insurance implications there's cost. There's obviously, you guys know this, there's costs with everything, but ensuring that what we are recommending aligns with, your values and aligns with, what you want to achieve. Some people are a lot more willing to kind of pull the trigger on surgery a little sooner, and that's fine too. But if, we want to extend the life of your native joint as long as possible, then you have the steroid injections and then these gel injections that are on the market now that we have had really, really good success with.
Oh, good.
They can extend the life of a joint for years.
Wow.
If used correctly.
And that's incredible because especially in like a frail older adult who may be having a lot of pain and really may not be a good surgical candidate, like theoretically, if it's done well, it can extend the life of that joint for the remainder of their life and give them relief.
That's exactly right. And I think that's what, I credit you and this podcast, because I think that can be something that gives you guys the empowerment and the knowledge to say, hey, I'm not ready for surgery. What options are out there for me? What am I a candidate for? And then being able to have somewhat of an educated conversation with your provider so that they can put everything out on the table and then you can choose as a team to make sure that, I'm ready to do injections, but let's say the injections, the steroid injections only last me, let's say a couple of months. What's the next step? And knowing what your path is forward, instead of being like, oh my gosh, I know I have osteoarthritis, I'm gonna have to have surgery within the year. That's not the case at all. That is something that has to be an individualized plan for each patient.
And so I went to an appointment with a patient last week, and it wasn't an ortho appointment. It was a different surgical specialty and surgical medical specialty, and the provider walks in and says, well, looks like I need to take you to the OR. And that was like before we'd ever had a conversation about like, what are the other options? Sure. Do you understand the goals of care of this person? Like, and I think that provider meant total, like, I think they meant well. Like, I don't think, and once we like engaged them in that conversation, they were very open to having it. But I think I'm always a little weary of like anyone who's like all right, need to get you in the OR today. You know, it's like, whoa, hold on. I think there's times when that's very appropriate, but like, it may not always be appropriate.
And that goes back to what we talked about a little earlier about, you know, if something just doesn't feel right, or you still have questions, there's nothing wrong with getting another opinion.
Yeah.
Just to see if they're aligned, to see if, you know, you feel like you have all the information that you need. And you're right, Chaeli, like having surgery right off the bat may be the best option. Yeah. And that may be exactly what you need as, you know, as the patient. But if you feel like you just need a little bit more time or want some more questions answered, totally okay to ask those.
Yeah, yeah. And I think too, in my experience, so like especially when I was in hospice, okay, so talking about like a very frail adult with like lots of comorbidities, maybe advanced dementia, whatever they have very advanced disease.
Sure.
And maybe they fall and fracture their hip.
Yeah.
And so the nurse would call me and say, oh my gosh, look at this x-ray, it's fractured, do I need to send to the ER?
Yeah.
And that would just start a conversation like with me and the family, like, what are our goals here? Would you do anything about this? Do you want them to just be comfortable?
Yeah.
And I think that it's difficult sometimes for providers, for the healthcare system, for families to like not fix something.
Sure.
You know?
Yeah.
And I think that like having a conversation and empowering them, like if it does not align with the goals of care, if it does not align with their Northern Star, with what matters most, maybe okay not to fix this.
I hear you. So hip fractures are extremely common. You know, especially as we get older, we deal with comorbidities like osteoporosis or osteopenia. And so, and then just as we get older in general, our proprioception or gait, kind of the way we walk, our balance, you know, it's not like we were when we were, you know, 10, 15, 20 years old.
Yep.
And so we are at risk for falling and then fracturing something. And I like the example you brought up about the hip, because that's something that can, you know, obviously change how you ambulate, how you get around. When it comes to evaluating hip fractures, obviously anytime a patient falls, there has to be an immediate assessment and evaluation, right?
Yep.
Ensuring that if there is a change in their status, whether it be a bruise, a sprain, or ultimately if it's a fracture, that has to be addressed. Now, what does addressed mean, right? Ensuring that you get the appropriate x-ray, that you've recognized that there is an injury, and then at that point having a discussion about, okay, what are your goals of care? When it comes to hip fractures in our elderly population or geriatric population, the risk of mortality and some morbidity goes up within the first year after that fracture in the hip has been identified.
I mean, just to be frank, as like geriatric provider, I mean, we often call it the beginning of the end when it happens. And I mean, I not to be insensitive, but I think anyone who listens to this podcast is like, yeah, grandma was doing fine.
Yeah.
Broke her hip and it was over.
Yeah.
You know.
It has been defined as kind of that sentinel event, like you said. And so being able to recognize, okay, we have a fracture, let's sit down and talk about how this is going to change moving forward. I will say, in orthopedics, we always want to give that outlook to the patient and the family so that they understand what this is going to look like moving forward. And surgery is always an option, right? It's always something that's on the table because it can extend the life of the patient if they were previously ambulating, correct? If you were, let's say you like to play pickleball, right? And that's something that is important to you, that was your quality of life before your fall, then yeah, you probably are a good candidate to get this hip fixed so that we can get you back to what you were doing before. But in the instance that you were talking about, you have patients that, let's say, are ultimately bedridden or maybe even wheelchair bound, and they fall when they're transferring from the bed or from the wheelchair to somewhere else. You know, there is, let's say you have identified that there's a fracture there. Does us doing surgery impact their quality of life, and does it impact their pain control?
Yep, that's right.
Because I think that addressing pain is also an indication to do a surgery, because that can severely impact quality of life.
Absolutely.
So I don't think it's automatically 100% yes, we have to take you to the operating room, but understanding that, how does this look for you moving forward? What was your family member's, let's say, quality of life or ambulation status prior to this incident? And how can we get you back to where you want to be before that?
Yeah, exactly. And so say it's someone who a family's concerned about, general anesthesia or things like that. Are there other options?
Yeah, for sure. So this is kind of where this collaborative approach with several providers, including anesthesia, including even the primary care physician, is really important. There, you don't necessarily have to always go under general anesthesia. There are options for, let's say, an epidural or even a local block type of scenario. I will say there is a lot of discussion that should be had before any of those decisions are made, and making sure that the right people are at the table to help make those decisions. So sometimes that involves almost like a pre-anesthesia appointment or a pre-surgery appointment with the anesthesia team or the anesthesiologist, so that they better understand, okay, what are the goals here? What are we most concerned about? And then if we need to pull in almost a team meeting with all the providers, including the surgeon plus the anesthesia team plus the primary care physician, so that we have a better understanding of what we're dealing with. But it doesn't always have to be just general anesthesia. There are other options out there that we can implement so that there is safe delivery of the surgery, and then also that you understand what you're getting into when you sign that dotted line to consent.
Yeah, love that. Okay, let's talk a little bit about, all right, so anyone who's listened to this podcast, anybody who knows me really knows that I do not like the emergency room.
Love it.
I think the emergency room, if I need to be in the emergency room, I have to really be there. But I don't like it for a patient. I think, we all know this, like, it's overutilized, and like there's a lot of things that primary care could, like, if in a perfect world, if our healthcare system was aligned just as I believe that it should be, primary care providers would have the time to address, they wouldn't have to react and be like, I gotta go to the ER, I've got 48 patients to see today, there's no way I can work you in, yada yada. But is there opportunity for, like, if you have an acute injury, like, is there opportunity for other settings for you to go to, like, and what does that look like rather than just go to the ER?
Sure, I hear you. This is a big initiative and a big push, specifically in larger health systems and even smaller health systems, understanding kind of these low acuity type of injuries and what is the right setting for those. I think that we can do a better job as a healthcare industry of defining what those pathways look like for our patients, because it can get very confusing.
Yes.
Where should you go? Where can you go?
It's confusing for providers. Like, I think that's why sometimes it's just like, go to the ER. I don't know what else to do.
I think that we are now starting to stand up, smaller urgent cares or even these freestanding ERs, but specifically urgent cares that can be very subspecialized. So, for example, there's an ortho urgent care at UAB that we utilize, I feel like, very well to try to shift some of the sprains, the strains, maybe long-standing joint pain to an urgent care type setting, or even into the ambulatory setting, instead of everybody has to go to the ER for something that may be bothering them for 20 or 30 years. Now, don't get me wrong. I think the ER is there for a purpose and for a reason. And we don't ever want people to shy away from the ER, especially for diagnoses that require that level of care.
Yeah.
But if we can treat, let's say you trip and you fall off of the sidewalk and you tweak your ankle. You know it's not broken because you can walk on it pretty well, but it's swelling. You're having some pain with moving it in certain directions, and you just want to get it looked at.
Yeah.
In those instances, I do think that there is a place for an urgent care, ortho urgent care, and even your primary care physician for that matter, to get a simple x-ray to understand, okay, what are we dealing with here? Do we need to escalate to a specialist? And can we just treat this more with a brace and some therapy, and you should be on your way?
Mm-hmm.
I also think that this pathway is bidirectional. Let's say you do choose an urgent care setting or your PCP, and there is indeed a fracture there that could have a dislocation component with it.
Mm-hmm.
Then in that instance, I do think that there is opportunity to create almost fast track pathways to get patients to a specialist or to an ED setting so that it can get treated correctly.
Yep.
I think that this is an area where I have a lot of passion about, because I think there's an education component that's also associated with it, because you always want the patient to see the right provider at the right time.
That's exactly right.
In the right place.
Yep, that's right.
And sometimes that just gets the water gets muddied because of the confusion on both sides of the street, the patient and the provider. So I 100% agree that there is opportunity for these lower acuity visits and certain types of diagnoses that we can see more in the clinic setting and then escalate as needed if we need to.
Yeah, totally agree. I love that. Yeah, there's so much opportunity there, and there's so much education that can be done and needs to be done, and hopefully as time goes on and we know better, we do better.
Right.
And, the right provider at the right time in the right place is so important.
Exactly. And this may be a bit taboo, but I think this is an area where AI can be potentially useful in creating some algorithms for maybe symptom checkers and things like that. I think we're still very, very early, and this is more just my personal philosophical approach, but I think that helps a little bit with that confusion, right?
Right.
Plugging something in to say, hey, I tripped off the sidewalk today and tweaked my ankle. Don't think it's broken. I think I need to see someone. Who should I see?
Yeah.
And I feel like there's some opportunity there just to kind of help clear the picture a little bit.
Yeah. Well, my husband is a professional ankle tweaker.
I love it.
And so he'll kill me for saying all this, but I'll say it anyway. He also just had gout several times, and then he actually broke his foot just stepping wrong off of the sidewalk at Waffle House one time.
I believe it.
I mean, there was no alcohol. It was just like a bad step, but it was like bam. So he everything that can be done, he has been done. So he knows exactly what to do and where to go now, because he's done it all.
I love it. That's awesome. And to me, but that happens to us every day, right?
Yeah.
Someone's going to call and say, hey, I did something to my knee last week. I don't know what's going on. I think I just need someone to take a look at it. Mm-hmm. And I think that's where we as frontline providers, and then now, in leadership in general, trying to implement pathways so that it's clear and that it's easy for the patient to know where to go so that they can get it looked at in a timely manner. And ultimately, if they still end up in the ER because that's where they need to be, then I think we've done our job.
Yeah.
But if we are able to avoid that in a way that's responsible and get them the care that's appropriate, then why not?
Yeah, totally agree. Let's in that same vein, let's talk about advanced imaging.
Okay.
That's one thing I was really intimidated about when I first became a provider.
Sure.
When to order it, which one to order,
sure,
contrast or not. And I got better over time. I felt it was fine. But initially, because a lot of times patients would just come in, they'd be like, this needs to bother me, I want an MRI.
Sure.
I know that we're not going to know what's going on with it until I get an MRI. And that's what I would like to have. Mm-hmm. But obviously there's conversation around that,
Sure.
What are your goals? And, getting more information and coming up with a plan together.
Mm-hmm.
But when is advanced imaging appropriate?
So a couple of things. Simple x-rays should always be somewhat your first line. It's cheap, it's effective, and it tells you a lot more than just what the bone is showing. The role of advanced imaging, and I referenced this early on, but I kind of brushed over it, but how is it going to change your treatment, right? Is ordering an MRI going to change how you are going to treat the patient sitting right in front of you?
Yeah.
And so sometimes that's just needing more information. Let's say that your clinical exam is unclear, or you're having a hard time distinguishing between two separate diagnoses. In that instance, you go back to the x-ray. If you're still not able to kind of develop a diagnosis from that, then 100% an MRI should be, or a CT scan for that matter, should be on the table. Now, to get an MRI, just to get an MRI, and you already know what your diagnosis is and your treatment is, I don't necessarily condone that. I think that's very cost ineffective.
Yeah.
I think it wastes time because you can't implement your treatment plan in a timely fashion. And I think that, as we're training, we should always be looking at what is the fastest, quickest way that we can get to a diagnosis and start treatment so that the patient can get back to what they want to do. If we're not able to do that from a clinical exam plus an x-ray, then that's immediately when advanced imaging should come into place. Now, how to determine which is which? I think you use the same algorithm. What can I get answers from the fastest and cheapest? And I love ultrasound. I think ultrasound is
Really underutilized.
Very underutilized.
Yeah.
And I like to use it because it's quick, it's fairly cheap, and it's not hurting the patient at all by doing it.
Yeah.
And sometimes you can even implement treatment at the same time as an ultrasound, like with injections. If you're doing maybe like a mass evaluation, if it's a ganglion cyst, sometimes we can implement treatment immediately.
Mm-hmm.
So let's say you've decided you want to do advanced imaging. There's another layer to that of understanding. It doesn't always have to be an MRI or CT. There are other options that we have out there, like nuclear stress testing, or just stress testing it, like in general, like bone scans type of thing, that are out there that can help us get to the bottom of what our diagnosis is. So I would say general principles are get a plain X-ray, understand what you can from that, not just looking at the bundle, looking at the soft tissues around it, relying on your clinical exam, and then also relying on what the patient has told you, right? There's a lot you can gain from history and your physical.
Yep.
And then if you're able to get to a diagnosis that you are very confident in, then I would go with that. Reevaluation is key, making sure you're following up with your provider within a certain time frame. If things are not better, then at that point you haven't lost anything, right? They're not worse, but they're not better. Then at that point you can start to implement some advanced imaging options.
Yeah, that makes total sense.
Sure.
That's a great way to approach it.
Yep.
Another thing is, so I think ortho and other specialties can complement each other in a way that's important. And sometimes it may be hard for patients or caregivers to differentiate, like, what's what and when do I see who. I mean, I'm kind of thinking about like how the ortho and rheumatology and I kind of think about like surgical ortho versus non-surgical, like in my brain at least, they're sort of separate things a little bit.
For sure.
Like, how does all of that complement each other?
Yeah.
Like if you're going to see your rheumatologist, like, how does it all work together?
So all of healthcare is intertwined, right? We are all so subspecialized now that it seems like we're all in very siloed or in particular buckets. But I will say orthopedics interacts with just about every subspecialty out there, whether it's rheumatology, neurology, endocrinology. There's a lot of our diabetic patient population that we treat. A lot of ortho diagnoses like trigger fingers that we deal with that are diabetic induced in some cases, or some of our diabetic patients are more prone to those.
Yeah. So when the blood vessels and nerves are affected from diabetes
exactly
in the
right.
joint space, it
That's
can create
exactly right.
numerous problems.
That's right. And so being able to reach across the street to the endocrinologist or even the PCP if they're managing it to say, hey, we want to get their A1C down to X. We're not comfortable doing surgery yet because we think that maybe there could be some improvement with their orthopedic diagnosis if their comorbidity is improved. And having that conversation instead of just being like, yeah, you have a trigger finger, it needs surgery, let's go do it right now. We're not necessarily solving the underlying problem because they're likely going to have another trigger finger in a few months if we don't get their diabetes under control or their A1C in a better spot. And don't get me wrong, like our PCPs and endocrinologists know that, but
Right.
kind of having a cohesive approach to say, hey, I hear you. You definitely have a problem or a diagnosis that we need to treat, but let's see if we can kind of get X, Y, and Z under control, and we may avoid a surgery. We may not have to make an incision, because once we make that incision, there are risks associated with that, right? You're now at an infection risk that's present there.
Yep.
There's a risk for other things down the road, like scar tissue, inability to maybe make a full fist because of that scar tissue that potentially could have been avoided. So there is so much collaboration that must occur, that has to occur, because we're looking at you as a full patient, not just one joint or one finger. It has to be a collaborative approach with everybody involved in the care.
Yeah, and I think advocating, like as a caregiver, as a patient, like advocating for that, you know, and sort of like just like letting them know that's the expectation in a way, like that's what you need. I mean, that's what we all need, and that's one thing about like one beautiful thing about being in a large health system that's well connected is, you know, like when you and I worked together, it was just like a message away, you know, it was so crazy. So there is, you know, there is some beauty in that.
That's exactly right. And honestly, that's our job as providers, right? Our job is to look at the patient as a whole person. Even though we can be so siloed in our subspecialties, we have to look at it in a holistic way. And being able to have those conversations, and sometimes, you know, you the patient, you just don't know what to ask or who to ask. And we have to be able to say, hey, you know what? Let me just reach out to Dr. X or specialty X and say, hey, this is what we're seeing today. We know that you're treating them. This is our plan, but we think that we can maybe collaborate on trying to make certain diagnosis better. You know, I think that's kind of the first step. And you know what? Even if you end up in the same spot that they came to you for surgery and that's where you end up, so be it.
Yeah.
But at least we've kind of answered some questions along the way so that everyone feels more comfortable in where we landed.
That's right. Knowledge is power.
Amen. Always.
Well, thank you so much.
My pleasure.
I learned a lot from you today.
I learn a lot from you all the time. So I'm very, very appreciative for the opportunity. Yeah, you guys are doing some great things.
Yeah, thank you so much. Everybody be sure to like, subscribe, share, tell your friends, and thanks so much for joining us.